Now coming to lung transplantation. This is the definitive treatment for end-stage pulmonary disease. All the lung is totally destroyed. The incidence of lung transplantation is increasing but still limited by the availability of donor organ. You need a brain dead patient to donate the lung. Here the recipient fall into four major categories. First and foremost is your pulmonary fibrosis, or it is usually idiopathic or associated with various connective tissue disorder. Second is chronic obstructive pulmonary disease. Third is cystic fibrosis or other congenital form of bronchiectasis. And the last is primary pulmonary hypertension. And there are some rare indications for lung transplantation, which includes primary bronchoalveolar lung cancer, lymphangioliomyomatosis, and those rare conditions where lung transplantation can be tried. For lung transplantation, there are several surgical options. You go with a single lung transplant, one lung is replaced, or you go for a double lung, bilateral sequential double lung transplantation, both lung is replaced, or you transplant the lung along with the heart, which is called heart-lung transplantation, or you go for a living related lobar transplantation. One lobe is being transplanted. Overall, 5-year survival rate is around 50 to 60%, but this survival depends upon the patient age and the complexity of the diagnosis. As the patient age is older and more complex is the diagnosis, the outcome is bad. Survival is generally better with double lung transplantation than single lung transplantation. However, the exception is elderly pulmonary fibrotic patient where there is no outcome difference between whether you do a single or double lung transplant. Now coming to the steps, this lung is totally destroyed and you remove the lung. The lung is totally removed and here you have bronchus, pulmonary artery and the left atrium, which has to be anastomosed from the donor lung, bronchial attachment, and next comes the pulmonary artery attachment, and third is the left atrial attachment. These are the steps in lung transplant. Here you can see all three are being anastomosed: bronchus, pulmonary artery and your left atrial attachment. Now coming to the anesthesia part, airway management is most commonly done with double lumen tube. By putting a double lumen tube, you allow direct continuous access to both lungs for suctioning, oxygenation and also to examine bronchial anastomosis. That is very important, and several advances have allowed the use of double lumen tube for lung transplantation. The use of segmental bronchial lavage. Here what you do is, first you place a single lumen tube, do the lavage, remove the secretion, and once the secretion is removed, place the double lumen tube for surgery. Coming to the monitoring for lung transplantation, you go with an invasive arterial line. Pulmonary artery catheter is very important in the post-operative period, and also transesophageal echocardiogram. Anesthetic maintenance is mainly intravenous infusion rather than inhalation agent. This is because there is a problem of maintaining stable level of your inhaled anesthetic vapor due to frequent need for suctioning and bronchoscopy. Each time you have to do suction and bronchoscopy, at the time you have to disconnect the circuit. So, maintaining a stable anesthetic vapor with inhalation agent is slightly difficult. In spite of advances in lung preservation technique, the donor lung ischemic time is usually less than 4 hours. You should restrict the ischemic period to less than 4 hours.